Ma'am, can I start?
Yeah, you can start.
Good evening, everyone. Myself, Dr. Hafiz from FCPI. Today, we are in the seventh presentation of critical care medicine of FCPI, and the today's topic we are going to discuss is about rapid sequential intubation. Life-saving procedure in emergency and critical care. So, as you know, this is a technique used to quickly and effectively secure the airway in patients who are at risk of aspiration or are in respiratory distress. So it involves it involves the administration of potent sedative and a paralytic agent to facilitate the endotracheal intubation. And the goal is to achieve rapid and safe airway control with minimum complication. So here we are, Dr. Harita is discussing about the various aspects of the RSA and the roles a clinical pharmacist can do in rapid sequential intubation, like selecting the proper sedative and paralytic agents. And a few words about Dr. Harida. Dr. Harida completed a Doctor of Pharmacy in the year 2022 from Amrita School of Pharmacy, Kochi. And currently, she's working as a clinical pharmacist in Department of Gastrointestinal Surgery and Solid Organ Transplantation at Amrita Hospital, Kochi. And she's predominantly focused on management of systemic disease among pre-transplant chronic liver disease patients and also post-transplant immunosuppressant patients. Now, I will go through the few of the participants' guideline. Can you move the slide? So, if you are having any questions, uh, uh, type or your
Hi, Hafiz. Can you hear me?
yeah, I can hear you. Can you move
Yeah,
to the next slide?
actually, yeah, your voice is breaking. So can I just, I'll just continue with the slides. It's
Oh,
okay
ma'am.
because I think your network is quite bad. So I think I'll just continue with the other next slides. Okay, is that okay for you? Okay, so I'll just proceed with the guidelines here. So for the feedback, yeah, so you can submit your feedback in the box that's available below. That submit your feedback option, which will be disabled after live session. So once you have submitted your feedback, you'll be able to claim the certificate of attendance, and it will be issued within the 14 days after attending the event. And also for the slides are available for download as PDF. So there is an option for the download, but for the file to be downloaded, you need to log in via FCPI itself. So with that, I will move on with my topic, which is rapid sequence intubation. So thank you so much, Hafiz, for the wonderful introduction. And I would like to thank FCPI once again for giving me this privilege of the online dais yet again. So without further ado, I shall start off with my topic. So I do not have any disclosures. So today, through my presentation, the topics that I would like to dwell upon are the following. First is basically the need for rapid sequence intubation or RSI. And also I'll be discussing about the different therapeutic options for sedation, analgesia, and paralysis. So airway management, it is one of the most important skills for any physician to master. And rapid sequence intubation or RSI is a cornerstone of emergency airway management. And I think if any physician can master that, then they'll be able to save like thousands of lives. So I think that's one of the most important factor there. Now, before jumping on to what is rapid sequence intubation and explaining about that, I think I need to brief on what is standard intubation. So I think most of you must be familiar about these terms, but I'm not sure how many of you must have seen this on a daily to daily basis. So standard intubation is the important point to be noted here is that the patient must be fasting for at least 4 hours. So that is, if the patient's stomach is full, there is a risk of vomiting and aspiration during intubation. And aspiration pneumonia, as you know, can be catastrophic. So during the standard intubation, the preliminary step or the first step is basically pre-oxygenation with bag and mask. So again, I think most of you must be familiar with this. Most of you must have seen it, at least in different series or movies that you must have seen. So pre-oxygenation is the most important step here. So why is that? Why is pre-oxygenation important? Because during the intubation, the primary thing is basically you induce unconsciousness, and then the next step is basically paralysis. So in such a state, what happens is that there isn't enough oxygen that's reaching your cells or tissues, and in such situation, your tissues or organs are becoming hypoxic. And as you know, once there is no enough oxygen in your cells, it can be the end result is not which we would be expecting. So after inducing unconsciousness, the paralytic agents are given. And this usually takes around 3 minutes. And this is the time when aspiration can occur. So coming back to my question again, why? Why is that aspiration risk is higher during this time? So something that you must have experienced some at least once or twice in your lifetime, that when you eat something and something that it usually goes into the esophagus and then the stomach, right? So by chance, by mistake, if it goes into your lungs, you tend to choke it out. You want to eject it out of your system. So it's basically a natural reflex of your body. But in a state of paralysis, once the paralytic agents are administered, your body is in a state of paralysis, and this reflex doesn't work. So in case the stomach contents or the gastric contents goes into your lungs, then that's when your aspiration can occur. And as I mentioned earlier, aspiration pneumonia is a catastrophic event. So that is a reason why standard intubation is only suggestive for elective patients who are fasting and have an empty stomach. So now coming to my topic, which is rapid sequence intubation. So I think from the term itself is pretty much clear. So what you're trying to do here is intubate the patient as rapidly and as safely as possible. And why would we do that? Because basically it is done in an emergency situation. So it can be a trauma patient, or in some emergency situations like that you will have to perform intubation. Because here you need to assume that the patient is not fasting, because it's an emergency situation. You cannot expect the patient to be fasting all the while, right? So the patient must be patient will be on full stomach. So this is a most effective means to avoid aspiration pneumonia after intubation, and it is useful in patients with full stomach as they are at much greater risk of aspiration. So here what we aim is basically induce immediate unconsciousness and muscular relaxation. Now, again, this is another term that you must have heard, which is crash intubation, but it's not a very commonly used medical term, but yeah, it is used around. So crash intubation. So when do you perform crash intubation, and how is it different from RSI? So crash intubation, the patient is already unconscious and apneic. So in such cases, you don't need to administer a pre-treatment or induction or paralytic agents, as in the case of RSI, where all these agents have to be administered. So that's the difference when you call crash intubation and an RSI. So RSI, there is simultaneous administration of sedatives, neuromuscular blocking agents to induce unconsciousness and paralysis, whereas crash intubation, you straight away intubate the patient as the patient's condition is already that's something mentioned. So what are the other indications for RSI? So what are those emergency situations or conditions where we can perform rapid sequence intubation? So first is when the patient has a reduced GCS score, patient has status epilepticus or post-cardiac arrest protection. Then it comes vomiting from gastrointestinal obstruction or regurgitation from diabetic gastroparesis, gastroesophageal reflux, and decreased lower esophageal sphincter tone. So these are the situations where you can perform RSI. So I think the objectives of RSI I have already mentioned below, but just to brief on it, first objective is to prevent hypoxia during induction intubation sequence. Second, to minimize the time between induction and tracheal intubation. So the aim is to use a fast-acting hypnotic agents along with a rapid-acting neuromuscular blocking agent. And third, and most importantly, to decrease the chance of pulmonary aspiration of gastric contents. So here you can see a very well mentioned steps of RSI. Actually, not just RSI, I think it's pretty much the steps that happens in the normal intubation as well. But as you can see here, very well written. They have written the time, how much time has to be taken for this process, for this step, and everything has been mentioned very well. But I don't know how many of you have actually witnessed an intubation process. So especially RSI, it's actually total chaos there, because you must have seen, I mean, or you will see a lot of people around the patient. There will be 2 3 nurses, then there will be an anesthetist, there will be another critical care intensivist, and there will be other technicians who will be helping around in administering the drugs or diluting the drugs. So it's not something, it's not like it's not a step by step procedure where you wait for one person to do one step, the other person to do the other step. So it's basically a chaos there, because we are all trying to save the patient there. So it's basically everything happens simultaneously, not as a step by step process. But this thing, I mean, this slide will help you in at least understanding what is to be given and why is it given and what are the different steps. So obviously the first, I mean, other than the step 3 and step 4, I won't be focusing on the other ones, because mainly these are the jobs of, very well, it will be done by the anesthetist and not by the pharmacist here. But yes, the step 3 and step 4 is basically the important one, where, you need to administer the drugs properly. So once the patient is prepared, once all the equipments are prepared, and once the patient is appropriately oxygenated, the next step comes is the pre-treatment agents, the administration of pre-treatment agents. And after that, it will be followed by induction agents and then paralytic agents. So that's what I'll be focusing on my coming slides. So the first and foremost is a pre-treatment agents. Now, why do we need to administer pre-treatment agents, and what is the indication for it? So as you know, when you intubate a patient, it's basically the process itself stimulates sympathetic and parasympathetic nerves, which innervates the airway. And as a result, there's a release of systemic catecholamines. Now, what will happen in such cases? So once there's a release of catecholamines, there are different physiological responses that happens. There is increased mean heart rate, then there is increased mean arterial blood pressure, arterial wall shear stress, and also other responses which stimulates the upper airway refluxes, precipitating cough, then there's laryngospasm and lower airway bronchospasm. So mainly what we aim is to mitigate these adverse physiological reactions to intubation with the help of these pre-treatment agents. So one thing to note here is that, which I've kept repeating again and again, it's not something that you administer as a step by step, like first you give this one and then you wait 3 minutes and you administer the other drug. So it's all administered quite along with each other, mainly because you need to know that it's a rapid sequence. It's not a standard intubation or an elective intubation. So you are in a situation where all these things has to be done very rapidly, and it has to be done simultaneously. So the different drugs or the different pre-treatment agents that we use are being listed here. So first is lidocaine, but again, lidocaine is not a commonly used drug, but yeah, it's one of the pre-treatment agents that can be used. Second, and the more commonly used drug, which is fentanyl. And third and most important, it is atropine. Again, it's not commonly used in elderly patients, but it is a drug of choice among the pediatric patients. So to get a clear understanding, I prepared a table here with the dose and onset of action. So one important thing as pharmacists we need to focus on is basically you need to know your drug. So what is the dose? What is the onset of action? Duration of action, and in what cases these drugs cannot be used. So these are the things that you need to focus on. So first, if you look at lidocaine, so as I said, it's not commonly used, but still, there are some situations where you tend to use it. So the dose of lidocaine which we use is 1.5 mg per kg. It has an onset of action of around 45 to 90 seconds, and the duration of action is shorter. It's actually 10 to 20 minutes. And the contraindication is bradycardia or severe heart block and amide allergy. Now, coming to fentanyl, which is the most commonly used drug, the dose comes to around 1 to 3 mcg per kg, and it has an immediate onset of action. So, which is the most important aspect when you look at RSI? So, what we need is something that induces which is a rapid acting hypnotic agent. So we give fentanyl, which is rapid onset of action, and the duration of action is also longer. It has around 1 hour. And also, compared to the other drugs, the side effect profile is comparatively lesser. It does have adverse effects, but obviously it's lesser. So there's chest wall rigidity and muscle rigidity. And contraindication includes respiratory depression and other hypersensitivity reactions. And atropine, I mentioned that it is something that we use in pediatric patients alone. So main reason is mainly because atropine it is actually contraindicated in patients with any heart diseases or arrhythmias, myocardial infarctions, congestive heart failure, tachycardia, and hypertension. So in situations where when there is a need to intubate the patient on an emergency basis, it's actually you never know. I mean, it's not necessary that you know all the medical history of the patients, and most of the time in these situations, a lot of things will be going up and down there. So it's always better to avoid such drugs which are actually contraindicated in such situations and go for the safe drug. So that's why I said it's important to know your drug. So you need to clearly know what the contraindications are and what the onset of action is or what the duration of action is in order to choose the drug for your patient. Okay, so that's your pre-treatment agents here. Now coming to the next one which you're going to use, which is the induction agent. So pre-treatment agent, as I mentioned, what you're trying to do is that you're trying to mitigate all those physiological responses to intubation. You're trying to calm the patient down. You don't need all those unnecessary responses towards intubation. Once that is done, your next step will be inducing the patient. That is the induction agents that you will use. And what you try to do here with the use of induction agent is first, in order to you need to produce a state of general anesthesia. So this allows for the administration of paralytics and facilitate a condition for general intubation. So you don't want your patient to be moving around, or you don't need the patient to be panicking around. So you need to calm the patient. So here the different agents that we use as inductions are: first, there is ultra short acting barbiturates, which includes thiopental and methotrexate. Then we have benzodiazepines, which is midazolam, and the other drugs, which includes etomidate, ketamine, and propofol. We'll just learn the drugs one by one. So first we have the ultra short acting barbiturates. So these are your CNS depressants. Now it has a rapid onset of action, and the approximate duration is around 5 to 10 minutes. So it has a rapid onset, but at the same time, it has a very short duration of action. Now, these two drugs, which is methotrexate and thiopental, it's actually not commonly used in an ICU setting. Even here, I haven't seen routinely being used these drugs. So there are different reasons. First of all, it's a barbiturate. There is a tendency for tolerance. Withdrawal and other symptoms, etc. And thiopental, main reason is that it is not an ideal agent for for sedation or induction of hemodynamically unstable patients. So it has a negative cardiovascular effect, like myocardial depression and peripheral vasodilation. So that's one reason why we do not prefer thiopental. But it is a reasonable choice for use in patients with elevated ICP, that is intracranial pressure, which is secondary to head injury, or in patients with status epilepticus. So in such cases, we tend to use thiopental because there are certain other drugs which are contraindicated in patients with status epilepticus or raised ICP. So in such cases, you can reserve the use of those drugs. Otherwise, it's better not to be used in an unstable patient because of the reasons I mentioned below. So coming to the other drugs that can be used as induction agents, first we have etomidate. So the dose given is 0.3 mg per kg. It has an onset of action of 1 minute, and the duration is around 3 to 5 minutes. Now here, one of the contraindication is that hypotension is contraindicated. So you never know what kind of situation the patient is. Maybe the patient must be hypotensive or hypertensive. So in cases where the patients are hypotensive, it's better to use it with caution. And if you have other drug of choice available, and if the patient is tolerant to it, then I think it will be better to choose the other drug. And the adverse effects, first is its adrenal suppression, then hypoventilation and apnea. Now coming to the next drug, which is propofol. Now, the dose of propofol, which we use, is 1.5 to 2.5 mg per kg. It has a more rapid onset of action, which is 30 seconds. And the duration of action is somewhat similar to etomidape, that is 3 to 10 minutes. And here, the adverse effect is, again, hypotension. So in case the patient is already hypotensive, it's better to avoid the use of propofol. And other adverse effects include some burning sensation at the site of injection and propofol infusion syndrome, which is PRIs, a PRIS, or we call it as PRIS. And the contraindication is hypersensitivity reactions. And lastly, we have ketamine. The dose we use is 1 to 2 mg per kg. Onset of action is around 45 to 60 seconds, and the duration of action is around 10 to 20 minutes. Here, the adverse effects includes increased ICP, hypertension, tachycardia, and laryngospasm. So, in cases a patient has a history of status epilepticus or has a head injury, or in such cases, it's better to avoid the use of ketamine. The contraindications include hypersensitivity or anaphylaxis. So if you ask which is actually, there are a lot of drugs which I have mentioned here, but which drug to choose and how do you know which drug to be chosen for this patient? So again, you need to know the contraindications and the adverse effect of each drug in order to choose it rightly for your patient. So usually it's said that ketamine is a reasonable choice for RSI, mainly because it has a quick onset and shorter duration of action. Second, there's a preservation of the respiratory drive, and it has sympathomimetic properties. But when you take propofol and etomidape, the main problem is that it has a more profound effect on blood pressure. And hence, it has a limited use in critically ill patients. So you need to you look at the you need to look at the vitals of the patient. You need to see if the patient is stable enough to actually use such drugs. Now, coming to our paralytic agents. So paralytic agents, so before we jump into the different agents that we use, we need to know the basics on what it is. So basically, it's neuromuscular blocking agents that we use. And what we tend to do with the drug is that we paralyze the skeletal muscles by blocking the impulse transmission at the neuromuscular junction. So as you know, there are two types, which is depolarizing and non-depolarizing agent. So to get a clear idea, I have you can see an image here. So you can see, so this one is the way where how depolarizing blockers work, whereas this one is how the non-depolarizing agents work. So if you look at this image, so this is our neuromuscular junction. And here, these green circles you see here, this is our acetylcholine. And this is our acetylcholine receptors at the neuromuscular junction. So when once we administer the depolarizing agents or depolarizing blockers, what they tend to do is that, so that's what you can see as these triangle agents. So these are our depolarizing blockers. So what they do is that they will come and they attach to these acetylcholine receptors. So basically there is no receptors free for acetylcholine to come and act on. So these are actually agonists, like they act more or less like acetylcholine itself, and therefore it, the drug binds to acetylcholine receptor and it actually causes depolarization, which is something that even acetylcholine does. And the same way, the drug stays on the receptor and it causes repeated contractions. So the calcium returns to storage and muscles is unresponsive to further contraction. So there will be some extent of contraction that is going on. So one example of your depolarizing blocker is the succinylcholine. Now, coming to the non-depolarizing blockers, it's a similar situation where, this is our acetylcholine, and these blue color square-shaped figures, these are our non-depolarizing neuromuscular blockers. So these are actually antagonists. So they have the opposite action. So what they do is that they will come and bind to the receptors and they do not cause any depolarization. And hence this calcium is not released from the storage and contraction does not occur. So that's mainly a difference between the depolarizing and the non-depolarizing blockers. So the examples of non-depolarizing blockers are rocuronium, vecuronium, atracurium. You must have heard about all these drugs. So coming to the actions and the dosages of each drug. So succinylcholine is actually the gold standard, or it has been the mainstay drug that is used for as paralytic agents. But it has certain adverse effects due to which its use is limited. Now, succinylcholine, the dose we prefer is 1 to 1.5 mg per kg. It has an onset of action of 45 to 60 seconds. Duration, it has a shorter duration of action compared to the non-depolarizing ones. It's only 10 to 15 minutes. And the adverse effect mainly, so if the patient has a renal impairment, so in such patients, renal failure patients, they are already in a state of hyperkalemia. So this drug itself causes hyperkalemia. So in such situations, it's actually contraindicated. Also, in patients with malignant hyperthermia, it is not recommended. The use is not recommended. And second, the non-depolarizing agent, which we commonly use actually in our hospital, is rocuronium. So rocuronium dose is 1.2 mg per kg. Onset is similar. It is 60 seconds, but the duration of action is actually longer. It's around 60 to 90 minutes. So here you can see in succinylcholine, it was only a shorter duration of action, 10 to 15 minutes. But rocuronium, there's a prolonged duration of action. Now, the adverse effects as such, it actually has a lower side effect profile, and therefore it's better tolerated among patients as well. Contraindications, it's basically hypersensitivity or anaphylaxis. So I haven't mentioned other drugs like becuronium or etracurium, mainly because it's not very commonly used because of its prolonged duration of action. In certain situations, we cannot use the drug. So since we have this drug, we actually commonly use rocuronium. So now that you know all these agents, you're familiar with the names, you're familiar with the contraindications, the adverse effects, I think you'll get a better idea once I start explaining it to you with different case scenarios. So here we have the first case. The doctor received an emergency call from casualty. Patient presented with severe abdominal pain radiating to the back. So provisional diagnosis of ruptured aneurysm was made, and patient collapses and goes into cardiac arrest. So my question here is, what intubation is to be performed here? So you need to focus on the details here. So first of all, the patient has collapsed and has gone into cardiac arrest. So in such situation, what kind of intubation would you perform? Is it a rapid sequence intubation? Is it a standard intubation, or is it a crash intubation? Which one would you prefer here? So yes, the answer is crash intubation. So as the patient is already in a state of apnea, or the patient is already unconscious. So in such cases, you don't actually need to administer the induction or paralytic agent. So what you perform here is a crash intubation. So moving on to the next case, we have a 56-year-old male, known cancer of stomach with gastric outlet obstruction. Now he has a full stomach and is posted for elective gastrectomy. But despite Reyes tube aspiration, stomach contents could not be emptied. So what intubation has to be performed here? So you might get confused here because I have mentioned here it's an elective gastrectomy, but at the same time, patient has a full stomach. And they have tried to aspirate it, but still the stomach contents could not be emptied. So now in this situation, what is the kind of intubation you should perform? Is it rapid sequence or is it standard intubation? So if you said standard intubation, you're wrong, because standard intubation has a higher risk of aspiration, and the patient will face aspiration pneumonia, and that's going to be catastrophic. So here, since the patient has a full stomach, we need to perform rapid sequence intubation. So why is that? The patient is at a high risk of aspiration pneumonia, and the induction and paralytic agents need to be administered simultaneously for rapid intubation. Now, same case, a different question. What is the ideal combination of induction and paralytic agent that can be used here? So you have different options. Is it going to be thiopental vecuronium? Is it atropine or rocuronium, propofol rocuronium, or methohexital and vecuronium? Okay, so the answer is propofol and rocuronium. Why? So can you use atropine and rocuronium here? No, because he's an elderly patient. Atropine has its own side effects and it is contraindicated in patients with arrhythmias. So it's better to avoid such drugs. So we'll go for propofol. Again, thiopental and vecuronium, as I said, it has a longer duration of action, and sometimes it's better to avoid it. So we go for a better option, which is the propofol and rocuronium. So next case, it's a 52-year-old male, obese patient with body weight of 99 kg. His BMI is around 36. Status post total gastrectomy for CA stomach. Now, post-operative day 5, he develops respiratory arrest and it requires intubation. Now, RSI was performed for this patient. Now, I need you to tell me what is the ideal choice of paralytic agent for this patient. So, is it succinylcholine, lidocaine, rocuronium, vicuronium? So first, you need to tell me which one is the odd one out here. So I asked for a choice of paralytic agent. So which among these is the odd one out? Are these all paralytic agents? No. So lidocaine is actually said to be a pre-treatment agent. It's not a paralytic agent. So this one is already off the list. Now, among the next three, which is succinylcholine, rocuronium, or vicuronium, which would you choose? So I think most of you must, you might choose rocuronium because, as I said, it has a lower side effect profile and etc. etc. But the issue is the answer is actually succinylcholine. Now, why is that? Why did I go for succinylcholine here? So here, if you look, I said it's an obese patient and the patient's body weight is around 99 kg. So in such situations, and when the patient is obese, you need to actually anticipate a difficult intubation because it's not necessary that every time you perform intubation for such patients, you get a clear airway. So it's going to be a difficult one. So if you choose a paralytic agent, which has a longer duration of action, that is around 60 to 90 minutes, and what if we are not able to intubate the patient and the patient is going to be paralyzed for the next 60 to 90 minutes? Then someone will have to continuously bag the patient, and which is not very a practical situation. So when you choose a drug, you also need to anticipate, I mean, how the patient condition and how is it going to be, what if it's a difficult intubation. So accordingly, you need to choose the drug. So here, it's better to go for succinylcholine because it has the onset time is quite similar. It's around 45 to 60 seconds. And the duration of action is also shorter. It's only 10 to 15 minutes compared to rocuronium, which has around 60 to 90 minutes. So it's better in such cases where you anticipate difficult intubation to go for drug which has a shorter duration of action. Okay. So moving forward, we have the next case here is a 15-year-old boy with a known history of epilepsy, comes to casualty with status epilepticus. During intubation, which agent would you not choose? So my question is, which induction agent is to be avoided, not used, which is to be avoided? Again, here, I would like to ask a question. Which one is the odd one out here? Are these all induction agents? No. So your rocuronium is the odd one out. It's a paralytic agent. So you need to move this out of your list. Now, among these three, which one would you choose? Oh, sorry, not which one would you choose, which is to be avoided. That's my question. So to be avoided is ketamine. Why? Because I mentioned ketamine has propensity to increase your intracranial pressure or ICP. And hence, it is always better to avoid use of these drugs in patients with history of epilepsy or when patient comes with epilepsy. So this is my last case here. So I think by this time you must be able to answer this question because it's very easy. So here we have a 60-year-old male patient with chronic renal failure and potassium is around 5.8. He has come up with traumatic brain injury and he requires RSI. Now, which agent is to be avoided to induce paralysis? So is it succinylcholine, vicuronium, rocuronium, metracuronium? So is there anything that can be avoided from the list here? Are these all paralytic agents or is there any odd one out drug here? No, these are all paralytic agents itself. So which one is to be avoided? So the answer is succinylcholine. Why? Succinylcholine is contraindicated in patients with hyperkalemia. So once a patient comes in with renal failure, you need to suspect, the patient has a hyperkalemia as such. So you don't need to cause hyperkalemia further. So it's better to avoid such drugs. Okay. So I think by now you might have got an idea on, how we choose the drugs and what are the main points to be considered. So it's not just, you might think that rapid sequence or intubation or, when you perform such procedures, it's only the work of the anesthetist or critical care intensivist to actually look into it. And it's not our job or, we might not have much role to play in it. But it's actually different because, as I said, the rapid sequence intubation process itself, it is actually it's a chaotic one. There are a lot of things that's going around here, and it's very difficult to know what to do for each patient or it's not necessary that you know the history of each patient, or a lot of things that has to be considered before choosing the drug. As I mentioned, there are a lot of contraindications, a lot of adverse effects that you need to look into, and also the duration of action as such. So what you can do as a pharmacist is basically you need to know the patient. You might be the one who must be knowing the history of the patient, so you can better contribute in choosing the drug. So the main key points that I would like to stress on again before finishing off my presentation is that first, in patients with risk of aspiration, RSI should be performed. Preparation is the key. So again, something that I told before itself, you need to know the drug, you need to know your patient, and accordingly, you need to choose the drug. So you need to be prepared for anything that can happen. Thirdly, be wary of difficult intubation. So in such cases, you need to use short-acting muscle relaxants. And again, know your patient and know your drug. So these are my references, and just a couple of updates on the upcoming presentations. So first, antimicrobial dosing in renal and hepatic impairment by Aisha Sana. So I think the presentation was already done before, but due to some technical reasons, the session is actually not available in YouTube currently. But the recorded session will be available soon in FCPI website and in YouTube as well. Next is Basics of Evidence-Based Medicine by Mohammed Rashid. It will be on Monday, 27th of May, 5 p.m. to 6 p.m. Next, we have Antibiotics Intravenous to Oral Switch on May 30th, 5 p.m. to 6 p.m. by Dr. Arya S. Kumar. And lastly, we have Antimicrobial Loading Dose and Maintenance Dose Concepts by Dr. Saidulu Ganta on June 15, 2024, Saturday, 6 p.m. to 7 p.m. So with that, I would like to end my presentation. I'm happy to answer your questions. Thank you for your patient listening.
Thank you, ma'am. Thank you for the wonderful presentation. And we have a few questions to ma'am regarding RSI. As like we are whoever the clinical pharmacist posted in the emergency department or critical care settings. Can you just brief about what are the various role, or in your experience, how does the involvement of a clinical pharmacist improve patient outcome during RSA, or what are the various role a clinical pharmacist can play during the rapid sequential intubation?
Okay. Thank you so much, Hafiz, for that wonderful question. So yeah, that's something that I mentioned just before ending my presentation. So that's one question that all of you might think, okay, so what can we contribute in such a situation? Because you might think that it's someone else's role or someone else's job to do it, and you're not well prepared for it or well educated for it. But the point here is that, as I said, a lot of things are happening because see, rapid sequence intubation itself, the term, it's like basically you're trying to achieve a situation very rapidly and as safely as possible. So you need a better outcome, and for that you actually need to know the patient, you need to know the history, and you need to choose a drug accordingly. So when such a situation happens, it's not necessary that the person who is there or the doctors who are there are necessarily the doctors who has been treating that patient, because it might be different, it might be night or whatever in such situations. So it's not necessary that the patient that they might know the patient's history, like, okay, this patient has a history of cardiac disease, or the patient has a history of epilepsy, a lot of things. So because your primary aim is to secure the safest airway possible. So if a clinical pharmacist is there 24/7, and if you know your patient, you can actually guide them on rightly choosing the drug, rightly choosing the dose, and rightly help in administering the drug. There are a lot of things that you can actually contribute into. So I think we should actually not step back in such situations. We should actually help them in selecting the right drug, and I think it will be helpful for them as well. We might think, okay, fine, they don't need our help, and there are a lot of other people that are helping around, but I think that's a misconception. And it's not just I keep saying that in the critical care setting, the reconciliation things are there, and the dose adjustments, antibiotics, and a lot of things that are other things as well. But these are actually important things where we need to contribute, or we need to start contributing as well, because it might be a big help for anyone, for the physicians, for the patient as well. So yeah, so that's what I feel is a better way where pharmacists can contribute in rapid sequence intubation.
Thank you, ma'am, for the wonderful explanation. And one of the last question is like, as you know, in the emergency department or the critical care, like we don't have enough time. In a short period of time, we have to take a smart action. And so, in a ward setting, for example, if a ward setting, if a patient require rapid sequential intubation, what steps should be followed, and will the necessary medications, as mentioned, typically be available in such a setting?
Yeah, again, wonderful question. Thank you. So you might think that, okay, it's only in the ICU setting where these drugs are available and the ward and all these drugs won't be there. So how would you perform such a RSI or intubation setting? So what you need to know is that all these emergency drugs, all these important drugs are already available in the ward because they have an emergency stock of all these drugs because it is mandatory. They have to keep the stock of all these drugs. So even if it is fentanyl or midaz or ketamine, etomidate, all these drugs, at least 1 or 2 vials will be there. So they have an emergency stock of all these drugs, and they have it's imperative. And in situations where the patient has to be intubated right away, that's why we have the code blue. So we right away inform the we call the code blue, and then the doctors they come in, and then nurses will come in, and they will help in all the situations they can. So even in the ward or in the ICU, it's not just that in the ICU we can perform this kind of procedures. Even in the ward also, there have been situations where we had to perform these conditions. So right away itself, they will shift the patient to the ICU and they will perform all the necessary actions. I hope that answers the question.
Yes, ma'am. Thank you so much. So we can wind up today's session. Thank you all for joining today's session. Thank you, ma'am.
Thank you so much, Hafiz. Thank you so much, FCPI, once